Good afternoon. My name is Ashley Haas. I'm the Director for Consumer Information at Benjamin Rose. Thank you for joining us for the 18th Annual Katz Policy Lecture on Mental Health and Aging. Today's webinar will be recorded. Throughout the session, feel free to submit questions using the Q&A or chat feature at the bottom of your screen. Our team is monitoring the chat to relay your questions to our presenters and assist with any technical inquiries. You can access captions by selecting Live Transcript, which is the button with 2 C's at the bottom of your screen. The recording of today's lecture and the accompanying PowerPoints will be available after the presentation and can be found in our resource library on our website, www.benrose.org, alongside all of our other webinar recordings, videos, and articles. If you are applying for CEUs today, they will be emailed to the address given at registration within the next few weeks. If you would like to engage with us on X or Twitter during the lecture, please use our handle at benrose1908 and the event hashtag #KatzLecture. Now I'll hand it over to our President and CEO, Orion Bell, who will introduce today's lecture and our keynote speaker. Orion?
All right, thanks so much, Ashley, and welcome everyone to this year's Katz Policy Lecture. My name is Orion Bell, and I am the CEO here at Benjamin Rose. And we're so pleased to have you join us today for our 18th Annual Katz Policy Lecture. This year, our focus is on exploring the challenges surrounding older adults' access to mental health care. The Katz Policy Lecture was established in 2007 to pay tribute to the esteemed legacy of Dr. Sidney Katz, who was a distinguished scholar at Benjamin Rose. The annual event serves as a platform for advocates to delve into potential policy solutions for critical aging issues. Dr. Katz was a multifaceted scholar, a physician, a scientist, an educator, a mentor, an author, and a public servant. He was a trailblazer in promoting active aging and advancing geriatric care, and helped to develop the concept of activities of daily living, or ADLs. The Katz family has remained steadfast supporters of Benjamin Rose, advocating for our mission over these many years. It is my great honor today to introduce this year's Katz lecturer, Dr. Matthew Fullen. Dr. Fullen is Associate Professor at Virginia Tech University, where he teaches in the Counselor Education Program and serves as affiliate faculty with Virginia Tech Center for Gerontology. Dr. Fullen's research, teaching, and advocacy focus on mental health and the needs of older adults, with an emphasis on addressing gaps in Medicare mental health policy and developing programs that enhance the mental health and wellness and prevent suicide amongst older adults. Prior to his academic career, Dr. Fullen was employed as a licensed mental health counselor, serving older adults in a variety of contexts, including long-term care settings, an adult day health center, and in private practice. Dr. Fullen has his BA degree from Northwestern University, an MA and Master of Divinity degree from Ashland Theological Seminary, and his Ph.D. from The Ohio State University. Please join me in welcoming Dr. Fullen.
Thank you so much. I'm going to get my slides here set up, and I'm thrilled to spend this afternoon with you talking about older adult mental health. I want to thank the Benjamin Rose Institute for the opportunity to serve as this year's keynote lecture. I really love your motto, "Let's rethink aging," and I'm hoping that today's remarks will allow us to rethink aging in the context of mental health, and also to rethink mental health in the context of aging. And I'm really pleased that today's lecture will continue the legacy of Dr. Sidney Katz, who, among so many other accomplishments, was a champion at both the state and federal level for older adults, especially in the realm of the nursing home industry. And I would like to begin our time today with a brief case study that I hope will set the stage for our time together. And I hope to bring to your attention several key features of Geraldine's story that are presented here on the screen. I had recently completed my graduate degree and achieved licensure as a professional counselor when I met Geraldine, a woman in her 80s who had recently moved into a long-term care setting for rehabilitation services. Geraldine was battling chronic bouts of COPD and frequent trips to the emergency room. She was referred to me by the staff social worker after staff had noticed that Geraldine was depressed. And I was told that she had been dealing with some significant losses in her life, but it wasn't clear until I met Geraldine just how much she was hurting. For people like Geraldine, access to mental health services is tenuous and too often non-existent. And so kudos to the staff at this site for noticing Geraldine's depression symptoms and believing that mental health treatment could help her. Because Geraldine was dually eligible for Medicaid in addition to Medicare, and because Ohio Medicaid allowed for robust mental health supports, Geraldine had access to mental health counseling from a licensed provider. Using a whole person lens for assessment, I learned that Geraldine was facing a litany of issues. Biologically, she was hampered by the COPD and emphysema symptoms that she was dealing with. She had to be placed on oxygen at all times. Her list of medications was long, and Geraldine was concerned about getting hooked, in her words, to the painkiller medication that she was receiving. Psychologically, Geraldine exhibited signs and symptoms of depression and anxiety, and she was struggling with family and grief issues, as well as many questions about this recent transition into a skilled nursing facility. She wondered, how long would I have to stay here? Can I return home to live with my daughter? Socially, Geraldine revealed to me that she had lost 2 of 5 adult children to tragic deaths, including a son who had died in the past year of brain cancer. Of her 3 living children, 2 of them lived out of state, while 1 daughter lived locally. And Geraldine shared with me worries about a family system that was both close and fractured at the same time. Now, one of the reasons why Geraldine's treatment was effective was because there was sufficient time for her to express the wide range of problems that she was facing. She learned quickly in our time together that all topics were appropriate. Her chronic illness, depression and anxiety, grief over deceased children, these were all interconnected pieces of Geraldine's puzzle, and to disregard any of them as irrelevant to her treatment would have been both foolish and invalidating. What also made our work together so illuminating to me was the contrast between what she was teaching me about her holistic needs and the biological reductionism that was apparent within the long-term care setting where she was living. Over the course of working within many of these settings, I found myself grappling with a severe disconnect between what Geraldine and so many people like her needed and the types of care that older adults, at least in some of these contexts, were being offered. This disconnect could really be boiled down to 2 primary observations. First, the vast majority of conversations that I overheard among staff and between staff and patients was focused on the body alone. And don't get me wrong, caring for physical and functional needs is incredibly important, and especially so given that functional limitations are typically a requirement to move into a setting like where Geraldine lived. But the more I got to know the people who lived there, the more apparent it became that the focus on physical functioning alone was missing something. In fact, it was missing almost everything that made Geraldine Geraldine. The second observation was that these conversations seemed to focus almost exclusively on problems, whether related to disease, physical functioning, behavior, or all of the above. Meanwhile, every conversation that I had with Geraldine illuminated how strong and resilient she really was. And the same was true for my other patients. Why then all the talk of correcting problems when patient strengths were right there in front of us? These 2 features, a focus on the body alone, as well as an emphasis on what was going wrong, conspired to create this dominant pattern that pervaded many of these environments where Geraldine and those like her lived. And let me assure you that this was not a phenomenon relegated to just one setting or one staff member. It was far more insidious than that. Imagine living in an environment where day after day, the primary topic of conversation is the various ways that your body is breaking down. What sort of a toll do you think that might have? And what if the lack of references to everything else that makes you tick? that makes you human. Nevertheless, thanks to what Geraldine was showing me about what she needed most, it became clear that mental health treatment, and talk therapy specifically, provided something that was lacking throughout Geraldine's care context. In our sessions together, Geraldine could be herself, her pains and her glories commingled. And through this process, many of her depression and anxiety symptoms dissipated. Treatment was working. Unfortunately, Geraldine's medical condition was also deteriorating. And eventually, she and her family concluded that hospice care was the next step. Now, hospice is a Medicare benefit, and Medicaid and Medicare were not particularly well aligned in the context of mental health services. In fact, professionals with my license at that time were not a part of the Medicare program. And I'll never forget receiving a phone call from my supervisor stating that Geraldine could no longer receive our services effective immediately. I would later find out that situations like these were impacting licensed mental health providers and their clients across the country due to outdated Medicare mental health provider policies and misalignment between public insurance programs like Medicaid and Medicare. After speaking with Geraldine about this sudden change, it became clear that she was at peace with her circumstances and was going to be okay. But I was deeply troubled by what seemed so nonsensical, so misaligned. It impressed upon me that, as I stated earlier, older adults' access to mental health care is tenuous, and changes to Medicare would be needed. Now, I want to broaden our conversation beyond just Geraldine's case and talk about mental health in general in older adulthood. On the whole, older adults experience the highest degrees of life satisfaction, even compared to people in young and middle life. And subjective well-being in older adulthood is particularly high when older adults perceive that they have adequate social support, a sense of control and mastery, opportunities to derive meaning, participation in preferred spiritual or religious practices, and a positive perception of their age. It really is possible to age well and to thrive in older adulthood. But there are many of these subsequent conditions that need to be in place for that to happen. And we know that not everybody experiences it this way. 20 to 25% of older adults meet criteria for a mental health condition, which represents a broad range of disorders, but we'll spend a little bit more time focused on depression. So in 2018, about 11% of respondents to a Medicare annual survey reported depression or anxiety symptoms. By August 2020, as the pandemic was in full swing, this number had increased to about 24% of all older adults, and about 48% of those who also had fair or poor health in their own description. So we know that older adult mental health is something that has become more in our public awareness, thanks in part to the pandemic, and is something that these effects of the pandemic are continuing to shake out. Now, when we look at depression specifically, we know that 21% roughly of older adults will experience depression in their lifetime. And when we drill down to specific estimates, such as major depressive disorder, it's about 5% in the community, but more like 12% of individuals who will report having some degree of depression or are being treated as such. And these numbers can fluctuate a little bit depending on living context or care contexts, as you can see here. But it's important to emphasize that depression is not a normal part of the aging experience, even though it does impact a significant number of older adults. And I hope if you take anything with you today, it's that depression, as well as other mental health conditions, are treatable. And there's reason to be hopeful about the ways that mental health care can support older people so that they can age well. Now, just a little bit more about depression in older adulthood. One of the reasons why it's important for us to talk about these topics is that depression in older adulthood can manifest a little bit differently than how it looks in other age groups. Older people are more likely to report anhedonia, the lack of interest or pleasure in daily activities, as opposed to reporting depressed mood verbatim. They may also be more likely to experience sleep concerns, feeling slowed down or fatigued, hopelessness, even memory issues. And depression in later life may be more likely to be comorbid with things like medical illness, stroke, diabetes, Parkinson's, cardiovascular disease, and dementia. So depression care in older adulthood, while being highly treatable, is also complex. And there's a need for mental health professionals to become well-versed in identifying and supporting older people as they navigate mental health conditions such as depression. In the context of depression, we should also talk about older adult suicide, which is routinely near the top of different age brackets when it comes to suicide rates in the United States. And according to the CDC, there was an 8% increase in older adult suicide between 2022 and 2023. Older people have a higher than average rate of suicide. And when we look specifically at older white men, particularly those age 85 up, the rate of suicide becomes about 3.5 times the national average. All of this just reflects the importance of thinking about older adult mental health and critically engaging with what that means for us as healthcare providers, social service providers, family members, or maybe us as people. What's notable is that in spite of what we know about older adult mental health, approximately 2/3 of older adults with mental health problems don't have treatment. And according to Stephen Bartels, a well-regarded physician and geriatrician, there is this conspicuous lack of national attention when it comes to thinking critically about older adult mental health, older adult substance use, and ensuring that the mental health workforce is set up accordingly. So why is it that there is this conspicuous lack of attention? And why is it that we can hear these things about rates of depression or even suicide risk, and yet also know that there is a real lack of mental health providers who specialize in aging? One of the explanations that I would propose to you today is that when we think about broad societal views of aging, and many of those views becoming increasingly negative and increasingly connected to the root of ageism, that has a negative impact on the availability of psychological services for older adults. Ng et al. Ran this study that looked at age bias over a 200-year period. And what they found is that there is this fairly linear trend that seemed to sort of turn a corner in the late 1800s. And then through most of the 20th century and the early 21st century, we have seen societal views of old age growing increasingly negative. The authors also found that there were two primary predictors that seem to coincide with these negative rates of ageism. One is the proportion of older people to younger people in the United States. So as more of the population became older, that seemed to coincide with more concerns, more fears, more negative attitudes about older adults. Give that some thought. We know that there are currently 12,000 people turning 65 every day. We know that there are societal demographic trends that will continue to increase rates of older adults compared to younger people in the United States and globally. And if there's anything to what Ng et al. Found in this study, we should be on the lookout for societal views of old age to continue to take that negative trend. The other key indicator that they found was what they called the medicalization of aging. Now, what do they mean by that? They defined this as viewing old age and viewing aging itself as a medical problem to be dealt with or to be solved, as opposed to looking at aging as a natural part of the life course and a natural part of the human experience. And so to the degree that these medicalized views of aging were most prominent, that seemed to coincide with these increasingly negative views of aging. Again, something to think about critically as we experience growing rates of older adults in our communities, and we think about how to ensure holistic care for these individuals. In a more recent study, it was found that among adults ages 50 to 80, over 80% of them reported one or more forms of what they called everyday ageism in their day-to-day lives. Nearly 2/3 had exposure to ageist messages. Nearly half had experienced ageism in interpersonal interactions, and over 1/3 reported some degree of internalized ageism. Now, when we think about internalized ageism and this idea that the age bias that we experience in our broader society also impacts how we ourselves think about aging, it's important to turn to the work of Dr. Becca Levy, a psychologist out of Yale University. And Dr. Levy and her team have looked at this internalization of ageism and noted some of the detrimental consequences to health and well-being that have ensued. And they've done myriad studies that link internalized negative views of age to things like longevity, the presence of Alzheimer's disease symptoms, changes to strength, gait, balance, etc. There's a whole host of negative implications of these views of negative age bias that we really want to tune into and try to address both in ourselves and in our loved ones. And I want to point you to one of the findings that Levy's team came up with early in this work, and it was a 7.5-year difference in longevity between those individuals who had the most positive views of aging and those individuals who had the most negative views of aging. And they used a whole host of control variables to try to really tease this out and drill down to this notion that your views of your own aging process can be the very thing that predicts how long you will live. And 7.5 years, when I first read that, I was incredulous. That is a huge amount of time. How could that possibly be the case? Particularly in context to other health behaviors. Levy points out that maintaining a healthy blood pressure and low cholesterol corresponds with about 4 years at the end of the lifespan. Not smoking and exercising regularly, 1 to 3 years. So 7.5 years that is linked to our views on aging. That's a big number. What they found, though, is that there are these key mediators such as will to live and engagement in health behaviors, the very things that keep us moving, keep us healthy, keep us socially engaged. When we have a more dim view of the aging process for ourselves, we tend to stop doing these things. So in a nutshell, when we deeply internalize ageism and then grow old in a society that reinforces age bias, we become susceptible to the belief that we no longer matter. And according to all this research, that belief can be deadly. So what's the link between ageism and negative age bias and mental health care? One of the links is that this sort of insidious ageism that pervades our way of thinking about ourselves and others, it really does reinforce several myths about older adult mental health. One of those myths is that depression is a normal part of aging. And as I mentioned before, it is not. Another myth is that somehow older adults are beyond the point where they can make changes in their lives. Many of our psychological interventions are built on this notion that we can make changes, whether those are changes to our behaviors, our thinking patterns, our relationships. And so if there's this notion that older people are somehow beyond change, then that can reduce our optimism about the mental health services and their effectiveness. These are also myths, and we want to make sure that we attack these head on. Not only that, but these age biases can reinforce this sort of lean toward biomedical ways of thinking about aging that take up all of the oxygen in the room and really remove us from conversations about, well, what about holistic care? What about mental health? What about social relationships? So we have to keep things balanced. And as you saw in the Geraldine case study, there's something about being able to see the whole person and being able to open up this broad range of issues and topics that are most meaningful to our clients and our patients that really does help us turn the corner when it comes to promoting health. Another detrimental effect of age bias is that when we have these dim views of the aging process, it limits our imagination around what it means to age. And again, I'll reflect on the Benjamin Rose motto, let's rethink aging. Well, we have to be able to rethink that by using the ingredients that are much more focused on what we look forward to about growing older, what strengths and assets aging brings to our communities, the benefits of intergenerational relationships and care. And ageism tends to eliminate many of those more strength-focused beliefs from the conversation. So all of these are just some of the ways that root of ageism begins to grow weeds in our aging imagination garden and starts to then choke out some of the growth that can happen. But not only this, it also very directly impacts what mental health and healthcare providers think about the benefits of mental health treatment. Kessler and Blachetta ran an interesting study where they had two groups of mental health providers. They gave each one a vignette. The vignettes were identical, with the only variable being the age of the hypothetical client. And in one vignette, this person was an older adult. And in the other vignette, this person was in their early 50s. And controlling for all of the other things happening, they just wanted to tease out, does the age itself seem to make a difference on the beliefs that these mental health providers have? And sure enough, it did. For the participants who had the 70-plus-year-old case vignette, they experienced more negative affect toward this individual, less conviction that the patient was treatable. They gave them a poorer prognosis. They had less interest in providing treatment, and they believed that they were less competent to provide treatment. You can see how ageism and negative age bias directly then impacts the provider viewpoint of what is possible with older clients. And it creates this sort of self-fulfilling prophecy where clinicians who have these ageist beliefs or healthcare providers who have these ageist beliefs are going to show up differently in the care that they provide for older people. And this can also lead to some of the things that we see across the country, such as a lack of mental health or healthcare providers who have specialized training in working with older adults, so who really want to ensure that older people have equitable access to services. Not only this, but this entire self-fulfilling prophecy can also amplify mental health stigma for older adults themselves. You know, if you're an older person who is struggling with depression and you have this notion that not everything is okay, and you're sort of hopeful that you might be able to do something about it, but in that short conversation with your primary care provider or with maybe somebody who knows a thing or two about mental health treatment, if you get the impression that they're sort of blowing off your depression symptoms or chalking it up to just, well, you're growing old, you know, what do you expect? Those are the sorts of things that are going to stigmatize mental health help seeking for older adults. So I hope what you can see is that this confluence of the ways that ageism interferes with our hope and our collective imagination and our collective will about expanding access to mental health treatment, and this negative age bias really can interfere with people getting the help that they deserve. So I began the Geraldine case study with reference to some of my professional experiences navigating both Medicaid and Medicare. And so I want to shift gears and spend a little bit of time talking about some key policy developments, particularly those related to the Medicare program. And this is an opportunity to report some really promising news and some really promising developments that have occurred in recent months. Just to give you a brief synopsis, the Medicare program came into existence in 1965 after decades of national debate about how we can collectively pool resources and create some sort of nationalized health insurance program that would benefit a vulnerable segment of our society. And so Medicare was born out of that collective will. Federal health insurance for people over age 65, as well as certain younger people with disabilities, people with end-stage renal disease, and people with ALS. And in 2024 terms, Medicare covers over 66 million Americans, which is about 19% of the American population. So this is a massive program that has major impact on the pursuit of health as well as mental health for older Americans, but many other people as well. And just as a note, in current terms, it's about 50-50 between Medicare recipients who are participating in Original Medicare, which is also known as Part B, and those who are enrolled in a Medicare Advantage plan, which is sometimes referred to as Medicare Part C. And so what we've seen is an increased enrollment in Medicare Advantage over the years, and currently these programs are just about 50-50 split when it comes to enrollment. So I'm excited to highlight some recent changes to the Original Medicare program. So that's what we'll primarily talk about: Medicare Part B, Medicare Fee-for-Service. These are all the synonymous ways that the program is referred to. And I thought it was important to highlight some comments from Dr. Meena Seshamani, CMS Administrator and Director of the Center for Medicare. And what Dr. Seshamani says is that, taken holistically, these recent changes are some of the largest changes ever toward a Medicare that recognizes people with Medicare as whole persons, with their own families and unique life stories. After all, people are more than the sum of their ailments and diagnoses. In light of my experiences working with Geraldine and many other people like her, this is music to my ears. It's, of course, important that we think about how to implement this vision that CMS is portraying. But the fact that they're thinking about person-centered care and thinking about the individual level experience of the Medicare program, I think is reason to be optimistic. So in terms of some recent changes to the Medicare program in regard to mental health, many of these changes were passed into law by Congress at the end of 2022 and went into effect January 1st of 2024. So not even 6 months ago. One of the changes is the addition of intensive outpatient program services that are offered within the Medicare program. IOP, or intensive outpatient programs, are part of the care continuum that are much more likely to be customary within Medicaid or within community mental health treatment. Historically, Medicare had not covered IOP, and so there was recognition that there was a bit of a gap between traditional outpatient mental health services and inpatient psychiatric services, which are far more intensive. IOP is meant to be another step on that continuum, which allows for more of a gradual transition, particularly for individuals who need something above and beyond your conventional outpatient services, but don't need to be hospitalized. And this is also more cost beneficial compared to something like hospitalization. Another change in this recent legislation was the addition of G codes related to mental health crisis response. And this allows for crisis services to be reimbursed when they're provided outside of a traditional mental health facility. And so really what is in mind here are things like mobile crisis response, which allows for authorized providers to be more responsive in their communities to go and take services to a crisis situation. We know that many times crises do not happen inside a community mental health clinic or an emergency department. The services provided in those contexts are obviously very important, but this change recognizes that sometimes we need to be able to take the crisis care to people out in the community. The third change to the workforce that I want to highlight is the addition of licensed mental health counselors and licensed marriage and family therapists. And these providers represent a significant proportion of the mental health workforce in the United States. These are individuals who provide psychotherapy and other counseling services to help individuals improve their mental health and well-being. In Ohio specifically, I wanted to highlight that these providers are identified as licensed professional clinical counselors, independent marriage and family therapists. Each state has a slightly different way of categorizing these individuals, but they all have in common graduate education at the master's level minimum, as well as supervised experience and state licensing that authorizes them to provide treatment for mental health disorders. And all of these mental health disorders impact older people. And so being able to open up this proportion of the workforce is really a major change in the Medicare program. Prior to, or I should say, the Medicare program was the last of the insurance programs to get on board with this, but all other public and private insurers already covered these licensed professionals. And so Medicare was really sort of getting up to speed with what was going on nationally prior to this point. Highlight a couple of interesting statistics about the scope of this change. There are conservatively 235,000 licensed mental health counselors, over 80,000 licensed marriage and family therapists. So in conjunction, we're talking about 315,000 plus new licensed professionals, new to the Medicare program, but individuals who are routinely providing services in their communities. And when you look at this in the context of other mental health providers, such as licensed clinical social work, licensed psychologists, these providers make up about 42% of the workforce. So really critical for the Medicare program to adopt this 42% so that there's less of this lack of providers available for Medicare recipients. In the first 3 months of 2024, since this all went into effect, there have been over 30,000 mental health counselors and MFTs who have enrolled in the Medicare program. And when you compare this to the 93,000 clinical social workers and 40,000 psychologists, and note that those professions have been part of Medicare going back to the 1980s, it really is an important addition to put these 30,000 new providers out there. That creates 30,000 new access points for Medicare recipients. And really, in addition to these other changes, can be the sort of thing that makes a difference in the pursuit of mental health for older people. I want to note some other changes. Telehealth really became a major part of service delivery during the pandemic. Medicare began to allow for telehealth, and some of those allowances were made permanent for behavioral health services specifically. There are still some things that need to be ironed out that CMS and Congress as well are continuing to consider, such as the occasional face-to-face session that authorizes then the majority of services to be done virtually using telehealth. Obviously, having that face-to-face requirement still in place makes it trickier to really do full absorption of a virtual caseload. But there's things like that need to be ironed out. But by and large, having this permanent fixture where telehealth can be used for behavioral health services is definitely a step in the right direction. Additionally, the recent legislation offered reimbursement codes for caregiver training. So now there's opportunities to help older adult caregivers receive some support, receive some psychoeducation on how to provide effective caregiving. There's also a new code related to the risk assessment for social determinants of health, as well as reimbursement codes for community health integration and principal illness navigation. And both of these are kind of a nod to the use of community health workers and/or peer support specialists. So again, these are opportunities for the Medicare program to get up to speed when it comes to health equity concerns. Many of these things are already part and parcel within the Medicaid program, but by Medicare creating opportunities for these to become a part of billable services. It gives community organizations that are providing mental health care more opportunities for wraparound services, continua of care, and doing things with a reimbursement mechanism behind it increases sustainability. Speaking of which, there were also built into these recent changes some slight adjustments for payment for behavioral health care, and these are applied to crisis services, substance use disorder treatment, as well as psychotherapy. There's also language around increasing the reimbursement rates for primary care, specifically due to the role that primary care provides in making mental health assessments and referrals. We know that Medicare recipients are far more accustomed to showing up at their primary care provider's office, and that may be where the front lines of depression, anxiety, other substance use, et cetera, may show up. So this is CMS trying to recognize that primary care has a key role to play here as well. Another important change is some payment rate adjustments to health behavior assessment and intervention services, also known as HBAI services. These are services that are primarily delivered in support of Medicare recipients who are diagnosed with physical health problems, but may be experiencing psychological, behavioral, or interpersonal challenges secondary to those physical health problems. And so these HBI services, which historically were provided by psychologists, can now also be provided by licensed clinical social workers, mental health counselors, marriage and family therapists. And they open up an additional way of supporting Medicare recipients. Again, being able to think more holistically about the ways that a physical medical condition may also have psychological or social consequences. So a lot of exciting changes to the Medicare program. And as I referenced, we're not even 6 months into these being live. And so there's going to need to be time for much of this to really be taken up by local providers. All that being said, there are challenges that continue to face the Medicare program when it comes to mental health. A few of those are listed here. Medicare continues to have a 190-day limit on inpatient psychiatric care. That sort of limit is not customary within some other health insurance programs. They also require a 20% coinsurance as well as the Part B deductible. And for individuals who don't also have Medicaid or Medigap, there may be barriers to affording those copays that could get in the way of an individual seeking out mental health care. Within Medicare Advantage specifically, which again comprises roughly half of Medicare recipients now, there have been some concerns about sufficiency of mental health provider networks. And so there are efforts underway at CMS to ensure that Medicare Advantage plans have mental health providers available in network. Otherwise, the benefits that are intended for these Medicare Advantage recipients are hard to actually take advantage of. And then another challenge that is ongoing is the lack of coverage for things like psychiatric rehabilitation and assertive community treatment, which tend to be resources that Medicaid uses for more severe mental illness cases. So still work to be done, but I hope you can see through the changes that have recently gone into effect that there is movement and momentum around what Medicare will cover vis-a-vis older adult mental health. Now, some of the challenges are not just at the insurance level, but they're about who takes responsibility for programs, for ensuring that people aren't slipping through the cracks. And so there have been this influx of state policy academies that focus on mental health, substance use, and aging, and state-level initiatives to try to align stakeholders who work at the state level in aging, mental health, substance use, Medicaid, long-term care, et cetera. These state policy academies have been recently facilitated by the E4 Center of Excellence out of Rush University. And this is a SAMHSA-funded center. with the guiding idea that these issues around older adult mental health, substance use, and aging are really not able to be solved by one single agency, but rather they require collective expertise and collaboration. And so these policy academies are intended to bring together leaders from these state agencies with the goal of providing services to meet the special needs of older adults with mental health or substance use disorders. And again, we're talking about specific agency leaders from mental health, aging, substance use, long-term care, et cetera, being able to come together, identify what's going well in their state, identify what some of the relative strengths might be from agency 1 to agency 2, and how they can coordinate policies and programs more effectively by all coming together. Some examples of strategies that have come out of these academies: efforts at the state level to enhance specialized training for the mental health workforce, efforts to train frontline direct care workers, as well as skilled nursing facility staff in terms of behavioral health of older adults. There have been efforts to expand the focus on primary care clinics and their ability to provide treatment, as well as learning how to capitalize on federal funding and HCBS waivers, as well as strengthening interagency coordination. So all of these are representative of steps forward at the state level that I think can really provide a nice template of what's possible when we collectively think about how do we serve older adults, how do we ensure that mental health, substance use are not something that are going overlooked or under-resourced when it comes to aging. Now, in the last couple of minutes, I just want to highlight a couple of programs specifically to give you an idea of ways that certain teams, including teams that I'm a part of, are trying to think about mental health promotion within the Aging Services Network. So much of what I've shared will directly impact what's available to healthcare providers, mental health agency providers, as well as federally qualified health centers, rural health clinics, hospitals, et cetera. But the Aging Services Network is another avenue where we can think creatively about how to infuse mental health supports and services. So the Aging Services Network, we're talking about well-regarded, well-trusted nutrition service programs, senior centers, area agencies on aging, places and spaces that are already well known and familiar to older people that are highly trusted within communities. And how do we think about building bridges between the aging network and mental health care? So part of what our team has been doing with funding from the Administration for Community Living is identifying specific ways to identify and refer older adults who are part of the aging network and who may benefit from mental health services and supportive programs. We then are aiming to build that bridge to the mental health provider community in a given state or locality, to use some of those changes to Medicare law to provide more services that can be offered with sustainability in mind, and to provide referrals from the aging network to mental health providers working in a community. And then to also think about how we bring mental health services into senior centers or into nutrition service programs. One project that we have been working on is to infuse nutrition services such as Meals on Wheels with some mental health basics. We developed a training focused on promoting belonging and empathy so that lay providers who volunteer within nutrition service programs can really make connecting with their nutrition service recipients more attainable. And this sort of connecting focused on some weekly supportive phone calls that can be delivered alongside the weekly meals. Some of this training is novel. Other parts of the training, we are incorporating the 2-day LivingWorks Assist suicide intervention training and using that to test whether that may be a viable way to equip these same individuals with more nuanced, tailored training that really focuses in on something like mental health distress and suicide prevention. We're also looking at piloting a program offered within senior centers that focuses on well-being and a more holistic way of thinking about aging and what people want as they pursue wellness in older adulthood. And this is intended to be something that removes some of that stigma that we may see older people experiencing around mental health care, and trying to create a program that, again, is operating within well-trusted places like a senior center, but allows them to think broadly about what they want for this chapter of life and how to pursue that. And finally, just to bring all of these different pieces together, I want to highlight some work that's being done in a particular state, North Carolina, that really, I think, just encapsulates how these different pieces at the policy level, at the program level, can all start to come together and build this groundswell of support for older adult mental health and institutionalize it in a way that allows this to be something that we're continuing to think about and innovate over the next 20, 30 years and beyond. So just briefly, within North Carolina, an organization operating out of Greensboro has been rolling out a series of webinars focused on Medicare provider enrollment and training. And they provide these webinars open access to anyone that's interested, but there's really a focus on, if you're part of these new Medicare mental health workforce, how do you get up and running? How do you make sure that the services you're providing are as age-friendly as possible? We see in North Carolina some senior centers that are beginning to offer mental health counseling on site, using local funding and Medicare changes for sustainability. We see the North Carolina Division of Aging and Adult Services really thinking about social isolation, loneliness, but linking those things to mental health distress, suicide prevention, and bringing in collaborators, including myself and other colleagues, to provide these trainings that I referenced, to try to equip professionals to think about how they can engage older people in their state. And then last but not least, we see the North Carolina Division of Aging partnering with the North Carolina Division of Mental Health to attend these one of these state policy academies and begin to think about, how do we put our collective wisdom together to make sure that older adult mental health is something that we are committed to for the long haul. So with that, I want to say thank you for the opportunity to share these remarks, and I'm looking forward to hearing some of your questions and hearing from our panel for the remainder of today's time.
Great. So, Dr. Fullen, want to thank you for that great presentation, and what a great opportunity to talk about rethinking aging, and great to have that today. And I know we have some questions that have come in through the Q&A and through the chat, so I'm going to look to Megan and Ashley to share some of those questions for Dr. Fullen.
Thanks, Orion. So we did have a question come in. The question is regarding ageism, and they were wondering what your experience shows, and what does the literature show that ageism, is it seen equally throughout the world, or is it more prevalent in certain areas of the world?
It's a great question, and one that sociologists and gerontologists have really been curious about as well. On one hand, we know that ageism is particularly problematic in the United States, and we know that, as one sociologist put it, that the United States, through globalization, has been pretty effective at exporting ageist views to other parts of the world. And so even parts of the world where we have maybe come to expect more reverence for older people or for intergenerational families and communities, that there's increases in ageism in some of those places as well. So that's not to say that there are not parts of the world that are far less challenged by ageism. And similarly, there are communities and pockets within the United States where ageism is far more of a foreign concept. And I think we have a lot to learn from looking to those communities that really have these strong intergenerational bonds and ties, and have maintained a sense of reverence for people across the lifespan, and have really come to view elders and older people as having a critical part to play in making, their community strong. And so finding those communities both domestically and globally, trying to understand how they have maintained that and trying to incorporate that into other ways that we think about aging, is probably a really critical next step as we try to ward off, future increases of ageism.
Thank you. Our next question, given the challenge in recruiting many kinds of healthcare professionals, such as nurses, doctors, etc., into the field of geriatrics, long-term services, and supports, are there any success stories that can be shared from the mental health space and how to get students interested in caring for older adults?
Absolutely. So I'll share a success story from my neck of the woods, and this is nothing that is vast or comprehensive, but just a kind of an anecdote. In Blacksburg, Virginia, which is where I live and work, we collaborated with a local continuing care retirement community where there was a focus on wellness and a focus on healthy aging, but really wasn't mental health services being offered. And so our department, which is a counselor training department, collaborated with this retirement community so that we have an intern who is placed as a mental health counselor in training and can work with residents of this long-term care community to provide mental health counseling pro bono on a regular basis. And what that has done is within this particular footprint of a continuing care retirement community, it has really removed any sort of stigma about mental health, about counseling, about psychotherapy. And we've seen over the course of several years of this collaboration, more and more interest in finding out whether services are available, an interest in, maybe they work with one of our grad students who then graduates, well, they're eager to then pick up where they left off with the next graduate student. Some of these community residents are really excited to contribute to the training side. They see it not just as receiving support, but also as a way to give back. And so we see that there are referrals happening from client to client, as well as from the community and the community social work staff to our program. So again, just one anecdote. There are other programs like this across the country, but it is always reassuring to see the way that the light bulb goes on for our graduate students once they have the opportunity to refute some of those age stereotypes and to really understand when you're working as a mental health professional with older adults, yes, there are some distinctive things that you want to learn. There's some distinctive things that you want to consider, but there is so much about that job experience that looks similar to working with people at other parts of the lifespan. It's relationships, it's people who are experiencing some sort of dissatisfaction with where life is right now. It's people who are feeling the press of the environment or of other expectations that are placed on them. And so it's nice to be able to see the way that the students reimagine aging over the course of getting more and more exposure to working with real older people.
That's great. Thank you, Dr. Fullen. We have time for about one more question. I know that there has been several that have come in. We had someone ask about ageism against potential future elders, such as current children now. He said that many currently have no health insurance or inadequate Medicaid, and they do not vote.
If you would, could you kind of restate the question
Yeah,
part?
sorry. It's
okay.
asking your thoughts about ageism, combating it with current children. Do you have some recommendations that you could make for how to kind of combat how children are being taught about ageism?
Yeah, absolutely. I referenced Dr. Becca Levy's work, and one thing that's really interesting about that, and I would encourage people to look into, is according to the stereotype embodiment theory, that is really the theory that describes how ageism operates in a society, it's something that we find ourselves swimming in from a very young age. We're exposed to these negative age stereotypes in childhood, through media, through social media, through conversations about aging, through what we see in the greeting card aisle. I know that in at least one of the schools in my community, there is a 100th day of school celebration, which invites students and teachers to dress up like centenarians. And you can imagine the sort of age stereotypes that sort of come into play with that. So the question is a good one. There really are this sort of dense negative messages about aging that we are trying to combat from a young age. I think part of what we do as parents, family members, loved ones is to try to challenge those stereotypes when they are reflected back, to try to have more critically engaged conversations about aging, to do our best not to reinforce age stereotypes in our own language, and to, invite curiosity about things like aging with children, adolescents, and other young people. Ultimately, and this is again a great point that Levy makes, when we have this sort of internalized ageism, we think that it is about those people out there, but it is going to affect us because we will ultimately become the target of ageism if we just live long enough to do that. So it really is imperative that we address that head on, and I appreciate the question from the listener.
Thank you. I'm going to turn it back over to Orion, who's going to introduce our panelists.
Great. Thank you again, Dr. Fullen. That was a great conversation. And for those of you that put a question in the Q&A that maybe we didn't get to live, we will be responding to those and sending the Q&A out to the folks that are registered for the webinar today. Now I have the great honor of introducing our reactor panel. So I'm just going to introduce them as they are on your screen here. And first, our first panelist is Tamar Cooper. Tam is a licensed independent social worker, supervisor, and licensed independent chemical dependency supervisor, and is the director of behavioral health services here at Benjamin Rose. She spent over 30 years working in the social work field in Ohio and Kentucky and focused her clinical and administrative skills on advocating for the mental health needs of underserved communities. Ms. Cooper has been with Benjamin Rose for 15 years, and she serves on numerous committees throughout Cuyahoga County and is a public speaker on mental health topics and provides training, education, and raising awareness for the needs and rights of people with mental health disorders. She holds a Master's of Social Service Administration degree from Case Western Reserve University and a Bachelor of Science in Journalism from Bowling Green State University in Bowling Green, Ohio. So we welcome Tam Cooper. Our second panelist today is Adrienne Green. Ms. Green is a licensed independent social work supervisor with almost 30 years of experience in the field of aging and mental health. Ms. Green started her career as a direct care provider in inpatient, adolescent, and adult mental health treatment and as an activities assistant in a nursing facility before she began her career in social work with Adult Protective Services. She's worked as an outpatient therapist in Community Mental Health Agency, as a Community Aging Service Social Service Director, and has managed an outpatient geriatric assessment clinic, and spent over 15 years in hospital-based inpatient geriatric psychiatry. There she held several positions, including Department Director. She joined Signature Health in September of 2022 as the Director of Geriatric Services. Let's extend a warm welcome to Adrienne Green. Our third panelist is Scott Osecki, and Scott is Chief Executive Officer for the Alcohol, Drug Addiction, and Mental Health Services Board of Cuyahoga County. He has been employed with the board in executive leadership capacities for more than 3 decades. Prior to being selected as Chief Executive Officer, he served as the Acting Chief Executive and Chief of External Affairs for the Adams Board in Cuyahoga County. In his role as the executive officer, he leads and oversees the staff at the Adams Board and is responsible for advocacy, planning, and management of recovery-oriented systems of care that deliver quality treatment and recovery services through their contracted agencies. And we welcome Scott to the panel. So, my first question for our panelists today is for Tam. How has Benjamin Rose reduced barriers and stigma for older adults in accessing mental health services and treatment? Tam, I think you're muted.
There we go. All right. Good afternoon, everyone. Well, historically, Benjamin Rose here in Cuyahoga County has been the only agency that's met clients in their own environment. So as you know, this is significant when you look at the many barriers that older adults face, such as mobility, those adults who are homebound, who lack transportation, and those who have mental health disorders that keep them from leaving their residence. Also, our behavioral health staff go into senior housing complexes, group homes, or we'll meet them at senior centers or wherever they need to be met. Also, we provide services, mental health services through telehealth, which again eliminates travel for older adults. And when there's any kind of a need for an emergency contact, that has really been very helpful. Now, the other pillars of service at Benjamin Rose, such as housing and financial services through ESOP, Rose Centers for Aging Well, our Senior Companion Program, and the We Care Because You Do Caregiver Support Program, work to support one another to provide care for our clients who come through our programs. And what that is important is that it provides not only just continuity for our clients, but it's a sense of familiarity, because with older adults, they really need that just sense of just feeling familiar. Change is difficult for all of us, but it's not a handing off, it's being able to walk somebody through. And that's what's really been very helpful here at Benjamin Rose. Also, another significant point here at Benjamin Rose is our Research Institute, which conducts aging studies, which focuses on issues that impact the aging journey, such as dementia, transgender, gender nonconforming older adult perspectives on aging, elder abuse, pet ownership, and the bond with older adults, etc. And our Research Institute and its team has been recognized for their innovative programs for older adults and family members and caregivers, such as our BRI Care Consultation, which has been delivered by over 60 licensed service organizations across the United States. And they are very well recognized for that. And that's been really important as they look at the different barriers that are faced by older adults. For our behavioral health program, again, this is our third year of funding supported through a federal state opioid and stimulant response grant, the SOS grant, that specifically has been targeted to work on eliminating barriers and stigma that, again, older adults are struggling with. And it been helpful for us to provide programming, training, education for the older adults to access mental health treatment. And our staff has been able to conduct, again, a number of mental health presentations and centers throughout the communities. Staff offers on-site grief and loss services. We do a number of suicide awareness presentations for older adults. And through our intake and BHS staff, we're able to provide information and referral services regarding mental health and substance use services. And what is helpful about that is that the person in the community doesn't have to travel to get those. They don't have to go through the cumbersome process of trying to have to look something up. All they have to do is make that phone call. And then one other significant piece about Benjamin Rose is that relationship building has been very important. And that's where Benjamin Rose has been very significant or been very successful. Our senior management plays a significant role making sure the needs of older adults are always before state, federal policy and lawmakers. And then on the local level, leadership is working to establish those partnerships that benefits all involved, and breaking down those barriers to access treatment. So we're very fortunate that we have that kind of leadership that makes those things successful.
Thank you, Tam. My next question is for Adrian. How do the current policies limit the provision of comprehensive wraparound behavioral health services for older adults? And if you could change policy, what's one you would change?
Thanks for that question. And thank you, Dr. Fullen, for such a great presentation. We could just rewind, and you certainly, I think if we rewatch your presentation, we have some of these answers. But I know we have folks on today from all over the country. And just for context, I work at an organization called Signature Health, which is a federally qualified health center and community mental health agency that provides care to folks of all ages across several counties here in Northeast Ohio. So that's kind of the context I bring today, is what are we doing to address the behavioral health needs of older adults in the context of a federally qualified health center. And certainly somebody who's been working with older adults for so many years in the area of mental health, I think certainly what you touched on today, Dr. Fullen, I would echo. We're thrilled with the recent changes this year, the ability to provide IOP services, which is a service that we do provide in the past for patients who were Medicare but did not have Medicaid. We either could not provide those services. We do have access to sliding fee scales, but a lot of our Medicare, not Medicaid folks would not be eligible for that. And what happens is you're dependent on local grants. You know, your local county mental health board might provide support. But the system is not designed for parity between Medicare and Medicaid. So Medicaid has really good comprehensive wraparound services available, but our seniors that are not dual eligible are often not eligible for that. So for example, case management, that's such an integral piece to comprehensive services. So, you know, we provide case management, peer support, psychiatry, counseling, nursing. We also provide primary care, dental, we have residential, a whole bunch of stuff. But for our Medicare folks, if they don't have Medicaid, again, case management is not covered. We're dependent on trying to seek out support for that, or we're large enough that we can absorb some of that cost, but small agencies might not be able to do that. So it's really not equitable for seniors, even within our region, let alone across the country, of what services they may have access to. The move towards expanding coverage for LPCCs and LIMFTs in the state of Ohio, those are our licenses, as you mentioned, is awesome. We still have some disparity where Medicaid folks can see people who are dependently licensed. So we have clinicians who would love to work more with older adults, but if they don't have their independent license, they still are not able to see our Medicare folks unless they're dual eligible. Those are some of the big things. I think that the telehealth issue is great. Again, it's been a wonderful resource for seniors. I think it's a double-edged sword because it gives people access, but it's often not the ideal way to provide services to seniors. We think it's really important to lay eyes on someone, to do a physical assessment, to really be able to see them. So Signature Health is providing the program that we've started. We are similar to what Tamar referenced, as them being the only ones in Cuyahoga County, really, that we're doing the in-home services. We're working on that within our service area, which again is several counties. I have a little team that's doing a pilot where we provide psychiatry services in the home, in assisted living, counseling, case management as a care at home team to try to reduce the need for telehealth, but it's challenging because the systems are designed for productivity and revenue. And when you're driving all around and doing all of that, you have to work within those systems. So I think that, the policy change for me, I think if we could get Medicare to pay for case management, that would be like at the top of my Christmas wish list, because it's just such a big need. So that would probably be my number one. Again, it's just better parity between what Medicare and Medicaid are covering. We have a lot of seniors who fall in that category where they are not Medicaid eligible, and they have lots of needs, and it's a barrier if they are out of network because of their Advantage plan, or they can't afford the co-pays and deductibles, and then they just don't get care.
Thank you.
Mm-hmm.
Next question is for Scott. And Scott, just from your perspective with the Adams Board, and maybe you might explain a little bit about what an Adams Board is for the folks outside of Ohio, but what are some of the barriers that you've identified that prevent older adults from accessing behavioral health supports, and how has the board worked to overcome some of this in our community?
Yeah, sure. Well, thanks a lot for having me part of this panel. I'm really honored to be a part of it. The Adams Board stands for the Alcohol, Drug Addiction, and Mental Health Services Board of Cuyahoga County, and we are a quasi-independent part of state and county government. And what we're responsible for is the planning, the funding, and then monitoring of public mental health and alcohol and other drug addiction treatment and recovery support services provided to the residents of Cuyahoga County. Now, there are 50 such boards around the state of Ohio, and we do not provide any direct service to individuals. What we do is currently we contract with over 70 providers to deliver mental health and addiction services to people not covered by Medicaid, as well as we deliver services to Medicaid recipients for services that aren't billable under Medicaid, such as the recovery supports, right? We got housing, vocational employment services, peer support, which is sometimes covered, sometimes not, prevention activities, our hotline, our crisis services, information and referral. So this is just a little bit, about what the Adams Board does. And we are governed by a volunteer board of 18 members. Right now, I think we have 15 or 16, but we'll soon to have a full complement of that. So from the Adams Board perspective, right, that many barriers can prevent older adults from accessing behavioral health education and services. So many of our board members and our employees are actually in that category of older adults. So we not only receive timely concerns about access from external sources, but internally as well, which is very helpful as we continue to, plan for services. So one barrier is the lack of, internet access, right? Or a complete understanding of certain types of technologies, right? So we know that, seeing individual or counselor online might not be comfortable for folks who may be elderly. So, and then we have some behavioral health resources that are online too. Like we have screening tools online that aren't a diagnosis or anything, but it tells you if an individual has, some type of a mental illness or addiction issue, and gives you information to go to your doctor to talk about. We also find mobility issues, right, also present a barrier, which can prevent older adults from physically attending, in-person programs. So, kind of like that double-edged sword you talked about, Adrian, in a different way, right? It's like it's hard to get there in person, but that might not be comfortable using the online resources that are there. But we do know that many of our agencies, we fund transportation programs, not only for the elderly, but for others. So at the board, we're actively trying to overcome these by strategically using grassroots efforts to reach people in their own neighborhoods, close to home, and with people whom they're already familiar with. So one example that comes to mind is our faith-based initiative that we have. So we know that many older adults have strong and trusted relationships with their places of worship. And we also know that when individuals, have an issue, certain individuals are comfortable going to their faith-based leaders first. So we partner with faith-based communities and other leaders, and we distribute information and materials directly to seniors and for the congregation, as well as to the individual leaders in the church parish, so they know how to address behavioral health issues. Grassroots wise, again, we also attend several events throughout the year targeted to seniors. So we continue to be a familiar face within the community. But one of the more difficult barriers to overcome, is the stigma around mental health treatment and recovery. Although stigmas are being reduced in other populations, there still may be mistrust, right, or discomfort among older adults when talking about mental health or other behavioral health issues. They don't want people to know, kind of like how cancer used to be back in the day. Nobody wanted to talk about that. So although, the younger populations and ever since COVID are more comfortable, in talking about behavioral health issues, we find that elderly adults are still not comfortable doing that. So, and so part of our messaging and thing is that it affects everyone, right? Mental health or addictions affect everyone, all age groups, all demographics, and people shouldn't be ashamed to seek treatment for that. So we want to make sure people know that. Also, which, interesting is that it's important for elderly folks, I think, to understand that addiction or mental health disorder are chronic brain diseases, right? That require long-term care, just like any other chronic illnesses they might have, such as, heart disease or high blood pressure or diabetes. And nobody's ashamed to seeking treatment for that, But, we do know that recovery is possible and it's life-changing for people, no matter what stage of life that you're in, So how we talk about mental health also goes a long way, right? So using positive language with folks, terms like emotional well-being, mental health support system, healthy coping mechanisms, instead of using old-fashioned, maybe negative terms when we do that. So, it'll take time to overcome many of our barriers, right? But I'm really encouraged, and the board is really encouraged to see the work of our partner agencies, including Benjamin Rose, right? Like we heard about all the things that they do, who work every day to ensure that people in our communities have access to the help they need. Oh, now you're muted, Maureen.
Let me fix that. Thank you. Thanks, Scott. So one of the things that Dr. Fullen touched on was just around some of the workforce challenges in terms of serving the older adult population. So Tam, my next question is directed to you at first, is that what are ways that community mental health providers are managing the shortage of available behavioral health professionals in meeting the needs in the community?
That's a good question. And hopefully my screen you guys can tolerate my screen to keep going in and out. So, well, there definitely has been a surge in demand for mental health and addiction services, and the shortage of qualified workers is significant. And again, it's going to take some time to adequately address this issue, but steps have been taken from the state to the county level to include these things. And we've heard Dr. Fullen talk about this. So some of the things that Benjamin Rose has been involved in is, again, offering student internships, both clinical as well as geriatric rotations for students pursuing social work degrees in undergraduate as well as graduate level programs. And we participate in the State of Ohio Great Minds Fellowship Program. And that Great Minds Fellowship Program, which is funded through the state of Ohio, provides financial support to students pursuing clinical behavioral health degrees, related degrees. And through that program, eligible students receive some financial support, as well as the agencies that participate with them. So that's a really nice thing. Also, and this relates back with Scott, who just spoke, we've participated in the county's Adams Board's workforce development project. And what that project is about, their goal is to educate potential workers about career opportunities in the behavioral health field and generate interest in young people who are looking at different careers. And it starts with really young kids, elementary, middle school, and high school. And there's videos and interviews for different professionals in the field, and they post these videos online, and people have talked about their careers and maybe how they've changed. And I participated in it, and it's used as part of the Cleveland Metropolitan School District's Career Connects program. And I think that that's really nice, because it starts out for kids in school and just gives them a great opportunity to consider what might be available. So another thing too to look at is under consideration is that interstate compact that would allow for counselors and social workers to practice in multiple states without being granted additional permissions from their state licensing board. And again, the Counselor Pact has already been passed, and the Social Worker Pact is still in legislation. For us, and I think maybe for some of the other agencies, assessing efficiency for use of staff by clustering cases for in-person visits and the use of telehealth is really helpful. But I would like to echo Adrian's comments that, you know, telehealth, you can't just only do telehealth and leave someone there and never see them. You must be concerned about the person's welfare and to continue to go out. So while it's a very helpful tool, reaching out to that client to ensure that they're okay. This is not something that's going to be solved quickly, but we're making progress. And I know through the Adams board and different things, state and local level, we're certainly trying to address that problem.
Any other folks on the panel want to respond to that one?
Yeah.
Heads nodding.
Yeah, if I could just add, you know, OMAS, the Ohio Department of Mental Health and Addiction Services, they have put funding behind this as well, right? So they even have a welcome back campaign coming back for those individuals who may have left for other careers to come back to the behavioral health field. And, you know, the Adams board is one of our priorities, right? To try to help out, to have our providers pay living wages. Right to folks. We know, you know, behavioral health is not an easy job. They need to take care of themselves. That years and years of schooling for some of those positions, and they need to be compensated for that. So we're trying to help out with that as much as we can.
Great, thank you. So Adrian, I'm going to direct a question to you. And we're talking about stigma and just sort of people's willingness or comfort in accessing help. What role does education play in reducing mental health stigma amongst the population? And how do you incorporate some of this into the work at Signature Health?
Sure. Well, you know, again, after Dr. Fullen's presentation, it really made me reflect on there's really two buckets of education, right? There's education to the community at large, to potential, you know, to folks who might be experiencing mental health issues, their families. I think that's really key for older adults is we want to get to seniors, but we also, their adult children. There's often a caregiver dynamic, which is not unlike the work that we do around children, where we look at that family system. We really look at that. And then we tend to, with younger adults, focus on the patient. But with older adults, we often need to broaden our perspective and look at who else is part of that person's life and who has influence over them. So certainly Signature Health, from a general reducing stigma, getting out there and educating people about mental health in general, we do all kinds of things. We do outreach, we do health fairs, we do events, we do advertising, we do all kinds of stuff. The geriatric focus is newer for us, and I'm thrilled to be part of an organization that actually kind of said, wait a second, the population is changing, and we know that these needs are not being met for many, many people. And so we're kind of at the front end of how we're going to address that. I personally think it's really important to like grassroots, get in front of people, go to the senior center, you know, do as much as you can to get just in front of people to talk about, you know, mental health is not an issue that is different when you're older adult, meaning that treatment works. It's not normal to be depressed. It's not normal to, we're not even talking about dementia today, but that whole issue of, people should have good mental health through their lifespan, and it's not normal to not have that. So, but to me, I think what Dr. Fullen highlighted was the stigma we have as professionals. So when we talk about workforce development, we can do all this work around behavioral health workforce, but if people don't want to work with older adults because they think there's no point, or it's not cute, or whatever, when we look at graduate programs of counseling and social work, how many people are on a geriatrics track or a focus where older adults is their clinical focus? And we know it's really small. There's only 1,500 geriatric psychiatrists in the whole country. So that's another thing we're doing internally, is trying to increase competence within our organization. We've done a 16-week didactic education program for our prescribers, which is nurse practitioners, PAs, and physicians. We are lucky enough that we do have a geriatric psychiatrist, and she did a 16-week geriatric psychiatry 101 training series. We've done an 8-week training series for our psychiatric RNs. And next on the list is counselors and case managers, because even though we're developing senior care teams, everybody needs to be able to have competent care for older adults. What are the special considerations? How do we need to be able to take care of these folks in a way that's competent? Not just, well, we provide case management, but if the case manager doesn't understand the system of senior care, are they going to really be helpful and useful? So to me, that's the education and also, the bridge between the senior care network and the mental health network. They're kind of like this, and we need them to be like this. So to me, that's just a big piece of education, is bridging some of those rivers that kind of keep us apart.
Thank you. That's great. Would mention there also that another example in Ohio, in other places, is the Geriatric Workforce Enhancement Program that's hosted at NeoMed, which is the Northeast Ohio School of Medicine, for those outside of Northeast Ohio. But great examples of GWEP programs around the country that are doing some of the same things, exposing folks in allied health fields of medicine and nursing and others to the opportunities to work in the gerontology and geriatric programs, and great opportunities there. And Scott, question for you: what are some ways that the Adams Board and its role is helping improve access to behavioral health services for the older adult population, particularly your focus on underserved or vulnerable communities?
Yeah. So the Adams Board, that, we are the payer of last resort, right? So we definitely, serve the underserved populations in Cuyahoga County. We have a great focus on that. So some of the things that we're doing, I know, like we're talking about stigma as well, is outreach to the different communities that we have, right? We have extensive marketing campaigns letting individuals know that services are available, that treatment works, that people do recover. Lately, we have been doing large advertising of 988. Right, that new national behavioral health hotline. So we're lucky here in Cuyahoga County that Frontline Service, which has been operating our hotline, is 216-623-6888 for over 30 years. That 988 is an easier number to remember, right? Kind of like 911 and also 211. We fund that as well, right? So perhaps the elderly population is more familiar with 211, right? Because that has been around for a while, where individuals could call and get referrals or information for services. So like I say, a lot of our thing is we're reaching out to those communities. We're reaching out with grassroots efforts, right? Like I said before, with that faith-based communities, how important that is for all people of all ages, but especially the elderly population. And we really want them to understand, right, that call 988, right? We think it's an easier number to remember. There's people on the other end of that line that will be able to help you, right? We're talking about training as well, right? That individuals that they should be able to interact with the elderly as well, like you were saying about that. So we have a training institute that we have here at the Adams Board, and we offer all sorts of various trainings. One of the questions in the chat there, I saw that somebody was asking about mental health first aid training to come out. The Adams Board, we do that for free. We do question persuade, we for suicide prevention training. So we go grassroots, right? Once again, to the faith-based, to community centers, to things like that, where the people are. That is really what we're trying to instill with all of our providers, is meeting people where they're at. So that's why we want to, make sure that we reach out and we're serving as many people than we can. Oh, I just wanted to add, interesting, when you were talking about if people want to work with the elderly, right? This is just whatever, showing how old I am, but back in the 90s, everything was geriatric. Do you remember take a course? It was geriatric communication. It was geriatric housing. It was things like that. So, but really though, right, where's the emphasis on geriatric mental health and behavioral health issues? That's really not there.
Okay. Finally, one more question for the panel before we open up to conversations for the panelists and for Dr. Fullen from folks that are online with us today. Just briefly as a closing, your thoughts about increasing access to mental health services for older adults, and something that really works or something that you'd change if you could, just briefly in 2 minutes.
I can get us started. I'm struck just through this dialogue at the complexity of making sure that mental health access is consistently provided in a high quality way. And it really does take sort of this village approach. It takes all of these stakeholders coming together, having events like this one where we can kind of take 2 hours out of our busy work afternoons and really think about a very specific challenge that faces communities across the country. And so, this is not something that is going to resolve on its own. This is something that's going to take a lot of dedicated energy. But I'll just say that, I'm very inspired by what I hear from our panelists, as well as what I see from our respondents in the chat and asking questions. It's always encouraging to hear other like-minded people want to address this. And the last thing I'll add is that when you have a focus on aging and mental health, you are probably, doing a lot of that work somewhat on your own. You might work in the aging sector and be one of few people thinking about mental health care, or you might work in the mental health field and be one of few people thinking about aging. And so it's really critical to create these sort of communities, like the community today, to be able to learn from each other, build up the work that's happening in all these incredible places, to learn more about what is working, so that we can, bring that into, the different communities where we have influence.
Great. Thank you so much. How about our other panelists? Any closing thought before we open up for questions from the audience?
Oh, go ahead, Adrienne.
Oh, thanks. I was just going to say, I've been kind of watching the chat a bit, and I'm so struck by the knowledge that's held by the folks here today. And again, we have people from all across the country and pockets of really good work that's happening. And so kind of figuring out the statewide policy education work groups, I love that idea. And Orion, I'm sure if that's happening already and I've missed it, you'll let me know, because those are the kind of things that I think that we need, is to get that multidisciplinary approach is. And again, like I said before, to me, it's just bridging the world of senior care and the world of mental health, because you're exactly right. Those of us that do this work, tend to be, I'm pretty passionate about it, and it's kind of selling the importance of both sides to the other side. And there is some really good work happening. We're lucky in Northeast Ohio to have organizations like Benjamin Rose and the work that they do with research, and they provide direct services in behavioral health, but there's so much more than that, which is very unusual, I suspect. And so we're lucky here to have kind of some initiative behind this, but there's so much work to be done even within our own service area, between rural, suburban, and urban in one region of one state. The things that you have access to as a consumer can vary greatly. So parity and the collaboration between senior services and the mental health side of things, to me, is just the key.
Yes, and I just want to add, when Dr. Fullen, you're talking about, right, increased Medicare, right, for doing that. So, like we serve most people, again, like right in the Medicaid community. But if our providers will be able to draw down additional funding through Medicare, right, it'll help raise the wages, again, of the individuals that are providing those services. It'll be able to increase billing and be able to increase services for individuals. So, I think that's an important thing to point out for our providers. But thank you.
Great. So Tam, before we open up, any closing thoughts? And I think you're muted. Sorry.
I just think, and I just want to speak for each of us professionals and the people who have boots on the ground, to include our clients, to look at the adult in the whole context of their environment. They're again echoing statements made earlier. The older adult is more than their diagnosis. And they're more than their age. As professionals, we need to remember to include that person in their decisions wherever they're at. That's key, to listen to them. As we talked about, the context of who we are, and there's not many people going in the field. Here we are sitting today talking about all the changes, and we have to be their advocates. And we've got all these people working really, really hard out in the field to do that. And we, as managers, as leaders, we need to listen to our staff, and we need to listen to the people that we're serving. And that's really important. And that's something that I know all of us sitting here, our board, the Adamus board, our leaders, and everybody, and to continue to be partners and to talk to one another.
Great, thank you. I'm going to ask for help from the other Benjamin Rose staff in terms of managing some of the questions from the audience. While we're queuing one of those up, I noticed there were several comments about coalitions or advocacy groups within your states or within your region, and just mention a couple, and somebody put one of them in the chat already. There's a National Coalition for Mental Health and Aging, which is a group of organizations that focus on behavioral health needs of older adults. There is usually a state committee or coalition in your state that you can learn about, and it's that national coalition is sponsored through the National Council on Aging, and there's some great information there about contacts in your state for that. For those of you that are in Ohio, that group is the Ohio Aging and Behavioral Health Alliance, and we are affiliated through the MAC, the Mental Health and Addiction Advocacy Coalition. Benjamin Rose is a member. The Adams board is a member. I think Adrian, you guys are members of that group. So there are a number of providers and advocacy groups around the state, part of that focus on advocacy effort around the issue, as well as some great information sharing amongst providers and consumers, and would encourage folks to seek those groups out for some peer support and opportunities, whatever state you're in. And with that, I'm going to ask Ashley if we have questions from the audience.
Thanks, Orion. And just to echo that, there are a lot of great resources that have been entered into the chat. So definitely make sure that you scan through there. And as Orion mentioned earlier, there have been quite a bit of questions. So we're not going to be able to address all of those today. When we email everyone afterwards and get those answers to the questions, we can also include some of those resources that Orion mentioned as well as that were in the chat. So going to some of the questions, we have two related questions. So to start with, we had an attendee that said, as you put forth programs and outreach, what are you doing with outreach to immigrant elders, especially immigrants of color, to include in a culturally sensitive way?
I could just say, can I just answer at the Adams board? We have a very robust diversity, equity, and inclusion 3-year strategic plan that we are working on. And one of our efforts was translating all our materials into various different languages. It's a whole bunch of them. I can't even remember all of them, but it does, for immigrants. And we actually even did some of our materials in Braille as well. So we are really active in this and encouraging our providers to do the same.
Thank you. Did anyone else want to comment?
I think that's another place where recruitment is important. Making a concerted effort to find staff and providers and peer counselors who look like and relate to folks they serve is important, and another component of those outreach efforts and diversity efforts in the not just with the people we serve, but with the folks who are the service providers is important too.
Thank you. So similar to that question, Tam, I believe that it was you that mentioned outreach to churches in particular. We had a participant who asked about if there was any outreach to any different religious houses, since there are many concerns related to cultural barriers that require a lot of education.
Yes, we do work with the different churches, faith leaders, and that's really an important component. And I think to Scott, through our local Adams board, has a faith initiative, so they do a lot. But that's really key, especially with older adults. So that is important, and we do that, and that works really well.
Yes,
I think Scott may want to talk a little more about his program through the board.
Yeah, so we have a faith-based committee actually. So our board is really, for years and years we have been doing this. That our board felt that faith-based is really important, right? So we reach out to all faiths, right? I know right now, Christian, Jewish faith. We're getting into the Muslim community as well right now, but we're looking into all faiths. So our next phase of we did a distribution to various churches through different organizations, to different congregations of a packet of information for the congregation, information for the pastors and the leaders of those churches. And we are going to be doing another one of those, and we're expanding, our outreach to various other different faiths as well. So yes, it's important.
Thanks, Scott. That's very encouraging to hear too. We had, did anyone else, want to react to that question or provide any additional information?
I guess I would just add that kind of ties in with the previous question about connecting with immigrants and folks who might not otherwise be going to the local senior center. They might not be utilizing media in the same way. So just the opportunity to get connected to faith-based organizations of all types, I think certainly can help to get to the folks who are least likely to connect to our traditional outreach efforts. So I think that's great that they're working on that.
Yeah, I like the way that you put that. Thank you. All right, our next question. I am a licensed social worker in the Midwest. We have recently encountered barriers for clients applying for long-term care and being denied admission based on severe mental health and suicidal ideation. Is there any insight or guidance on how we can best advocate for clients for the need for long-term care and who have severe mental diagnoses?
Okay, Adrian.
I didn't know if Dr. Fullen was going to jump on that one. Well, how much time do we have left? That is, I mean, we could have a whole day on that topic. There are huge issues with this topic. Again, when we talk about the silos of seniors who have co-occurring mental health disorders, suicidal ideation, particularly if it's kind of a chronic subacute suicidal ideation, is a major problem because long-term care facilities, assisted livings, nursing facilities are not designed to meet the needs. They're not mental health facilities. There is no such thing. I'm always fascinated. Well, at least in the state of Ohio, people will say, well, like, put them in a long-term psychiatric place. Well, that doesn't really exist. There's particularly for older adults who really what they need is nursing care. So I don't have a good, easy answer. It's a huge barrier. I can tell you on somebody who was on the hospital side for many years, we would have patients who were stranded in the hospital because the long-term care facilities are not incentivized to provide care to those folks, to that population. So if anybody else, Dr. Fullen, if there's things happening in other parts of the country in this area, but yeah, the overlap between mental health aging and long-term care is quite complex and very challenging for sure, especially if people do not have co-occurring significant physical health issues. So folks who can't take care of themselves due to their significant mental health issues, they are older, but maybe they don't need nursing care. They're not in a wheelchair. They don't have wound care. They don't, it can be really, really challenging. So I wish I had a great, yes, here's the ticket, but it's a highly complex and challenging issue.
Dr. Fullen, I know this is part of your area of study. Is there an example of something that you've seen that you'd share?
I think Adrian said it very well. My initial response is just one of discouragement and frustration, of course. Not that these complex cases are out there, but that there is this sort of kind of black and white thinking around what our response is to that. So, I think to just kind of piggyback off of Adrian's comments, we may not have this well solved yet, but I think if we can begin to continue to re-envision, what mental health supports do look like within a variety of kind of aging-based contexts, we will see incrementally more and more capacity, maybe not for the most severe cases that we could imagine, but for cases on that spectrum that right now, because of stigma, because of a lack of training, a lack of awareness around older adult mental health, we may find ourselves today with more of that reactionary, oh yeah, we don't want to admit that person, or we don't have a mechanism to support them. Well, perhaps that's a starting point and not an ending point. So, I do tend to think about these things optimistically over the longer haul. And you saw in the reference to those state policy academies, some of what was coming out of that. And again, keep in mind, those policy academies bring together aging and mental health and long-term care and Medicaid. These are some really brilliant people who have a lot of influence over how the different state programs can operate. And some of the work that was coming out of those academies was training those long-term care employees so that they are more capable of responding to mental health needs that may come up. So that doesn't mean, I don't want to diminish how challenging the most complex, most challenging cases may still be, but I think there is this entire spectrum, and the more we can make that incremental improvement in the direction of having more dexterity around aging and mental health, we're going to allow for more people to get the right sort of services. And our thinking then can go toward, well, what do we do with these really tricky cases? But I'm confident if you get those state level leaders in the same room, probably going to be able to figure some of this out.
And I just wanted to piggyback off that again, too, is on a positive note. That is one of the things that we are doing with my little program. We go into about 20 different places, group homes, assisted livings, and a couple nursing homes. And that does provide a facility that might have otherwise been reluctant to accept somebody because of their mental health concerns, knowing that there is staff that's going to be able to come in and support that. And of course, there's plenty of organizations. There are companies that all they do is long-term care mental health. So that is an emerging area of focus, I think. So I did want to echo that there is some sunlight on the horizon. I think particularly folks who are not the most severely and chronically ill, is that more and more you can get care coming into facilities, and which is one of the things we're doing.
And a couple of sort of connected to that, with the population, a lot of states, have made really effective use of Medicaid waiver programs that have allowed for some community supports for people, nursing home level of care, but receive services in the community. A lot of states use that to fund some assisted living for lower income adults and some pretty incredible levels of support for people. Unfortunately, there's not really a category in there for behavioral health or those targets within that space. And so not only is it difficult in the institutional setting, but it's also difficult for people transitioning back out of a rehab facility or back into a community setting for some of the same reasons. So as we think about the policy components of that, looking at what we can do with Medicaid waiver programs for the folks who qualify for that, how we address behavioral health needs, including diagnosis and treatment in the pre-admission screening process for nursing home admission in states, is another place that we should be able to address that. We just don't, it's messy. We don't have good models in place yet, but I think we've moved at least to the point of being able to identify the problem well, and that's the first step in being able to come up with some effective solutions to address the question that was raised.
And I want to amplify, one of our participants posted about a center of excellence focused on behavioral health in long-term care that is supported by SAMHSA and CMS. So that's really encouraging. So in spite of these complex challenges, there is work that's being done. That's incredible. And I feel like really exemplifies the spirit of Dr. Katz. Nursing home-based or long-term care-based advocacy, and what are those things that are facing us now in 2024? Maybe this is one of the pieces that we can channel that spirit.
Thanks.
Would anyone else like to add anything? All right, so we have time for about one more question. So this participant said, it still seems that the major issues for older adult mental health is still related to money. In our state, which is Utah, unless you're on Medicare or Medicaid, mental health services for older adults are generally ignored with very meager services. Who can we work with at the state and or federal level to address this?
I guess it'd be SAMHSA, right? The Substance Abuse Mental Health Service Administration at the federal level. I was just throwing that out there. Sorry, Orion, I know you were going to say something. And I have to run because I have a 3 o'clock that I have to be on. So thank you all, everybody. Okay.
Thank you, Scott.
Bye.
Thanks, Scott. So that's another place, again, on the advocacy component, another place to suggest reaching out to the National Coalition for Mental Health and Aging and finding out about the state program that may exist in your state, Utah or others, about ways of addressing that. There are most older adults are covered in the U.S. are covered through Medicare or VA benefits as a retiree, and so looking at those programs and seeing what services are available, and if there needs to be attention paid to reimbursement rates or eligibility questions or provider services available, and those things are all interrelated. Those are places to start in terms of things you can do at that level. A lot of these are state level conversations because insurance is regulated, particularly Medicaid and private insurance is regulated at the state level, and has a lot of impact on what's there and how services are provided. So there are opportunities to speak to that and address that. Sure, at the state level, it's not always a federal response, and it's always important that those two are on the same page.
Thank you. Did anyone else have anything to add? All right. Well, that brings us to the end of our webinar. So thank you all for being a part of our 18th annual Katz Policy Lecture and for all of the many engaging questions and wonderful resources that were provided. We just really appreciate all of the engagement today. And a special thank you goes out to Dr. Fullen and all of our esteemed panelists for their very insightful presentations. We're very grateful to have such wonderful experts on the webinar today. As we strive to enhance our future programs, we kindly ask for your feedback through a brief evaluation survey. Your participation is voluntary and all responses will be kept anonymous. You can access the survey by clicking the link provided in the chat, and it will also be sent to you via email after today's lecture. And just as a reminder about the CUs, they will be emailed in the next few weeks to the email address given at registration. So if you already put in your license number in the question that was asked during registration, or if you already emailed it to me individually, you do not need to do anything else. However, if you still need to provide us with your license number, then please send it to us in an individual message, again, to ahaas, AHAAS, @benrose.org. And make sure you send those by the close of business on Friday so we can get those out as soon as possible. So we want to extend a warm invitation to explore our upcoming free events that are here on the screen. For further details and registration, as well to learn more about Benjamin Rose's research, programs, and services, please visit our website at www.benrose.org. Thank you so much again for joining us, and we look forward to seeing you again all next year. Thank you.
Thanks.